Dr. Prem is here, I think, and he has been quietly sitting behind, listening to us. Dr. Prem, please come forward. Sorry, I could not welcome you before I saw you enter, but how are you? You want a collar mic or this is okay? Just check it. Dr. Kumar will help me with this interview talk. Dr. Prem, what we have done is all the three speakers, we have already forwarded them the introduction, the formal introduction of the speakers. So what we like is a more informal introduction of the speakers. So first of all, tell us, where are you from?
Yeah, so I'm basically from Kerala, but I've never lived there. So I was born and brought up in Bombay and Delhi. And since MBBS, I was away from Bombay actually, to be very frank. I have traveled to Aurangabad, then to Kochi, then to Delhi back, and then Bombay. So
you did your MD in Geriatrics?
Yeah. So I did my MD in Geriatrics from Amrita Institute of Medicine, Kochi. So I was the first batch there, yeah.
Okay. How many Geriatrics MD physicians are there in the country, you think?
So I will, to put it in perspective, when I did my MD in Geriatrics, I was the second college. So now there are 25 colleges. So the number of MDs which are coming off almost yearly is more than 100 now.
Wow.
Yeah.
And that still must be a shortfall.
Yeah, absolutely.
And which is why I think we are encouraging our family physicians, because they are in touch with, to become kind of geriatricians if they can within their outpatient realm. What do you think? What is the need of training for geriatrics for the family physician? Formal training. They see, of course, they are already trained in some ways. But do you think any formal training should be done?
I think one of the major things is because most of the times, if not most, or maybe almost every time, family physicians are the first point of contact. And I usually say you should know more about geriatrics, not because you want to treat patients, but you are going to get old one day. A lot of us are already old. So be selfish in that way to know more about geriatrics so that you can treat not only your patients, but yourself better. So I think there are a lot of courses now, especially, online, there is something known as PGDGM, which is there of IGNU, which has been there for a while. So, and then of course, there are short courses like even Public Health Foundation of India has, which I have been a part of. So those are available. And of course, we keep doing some soft sort of skills workshops as well. So I think these would be the best ways. According to me, most of you all have experience in seeing old people. Maybe the only difference is what has happened is everything has been put into a concise subject and made more professionally as compared to maybe where we were seeing patients, but maybe we have to see them with a different perspective. That's it.
Any hobbies that you cultivated?
Yeah, I do. I was a poet, but I have not written some for a while because it helped me to get married. So after that, I didn't need it. Apart from that, yeah, very occasionally singing. Yeah.
Okay. Do you remember any poem of yours? And are they in English, Hindi?
I usually English and Hindi both. But to be frank, I don't think I'll remember. Maybe when we end, we should get something.
We can try. Okay, so I asked him about what are the topics he would like to cover in the limited time that we have. And he gave me 3 areas. One is orthogeriatrics, meaning orthopedic problems in geriatrics, including the subject of falls. In fact, we are celebrating a fall month within our educational group where we are learning about falls. The second area he said was dementia or cognitive disorders, and the third area was incontinence. So three of the major areas, 3 of maybe 5 to 6 major areas within geriatrics. We have learned about geriatric giants from Dr. Alka Ganesh, who had come in to teach us once. Can you revise for us what are geriatric giants?
Yeah, so Professor Alka, of course, is one of the foremost mentors. I mean, before I go into geriatric science, just one small thing about her. I think she was one of the first few to actually take initiative in sending her students abroad to actually get trained in geriatrics. So, I mean, Professor Matthews, Prasad Matthews, Professor Surekha, Gopinath, these are the three big names in CMC Vellore. But all of them are trained abroad. So they were there, but then ma'am sent them. So that was one of the very good initiatives. And Geriatric Giants, I think, is there in the name itself. It's very close to me because the first day of MD, I was asked this question and I didn't know it. So,
Okay.
so basically, it has a very big D's. So that is depression, dementia, delirium. So we see these very often. Depression is something you don't look for it, you won't see it. Dementia, of course, we will be talking about it a bit. Depression and dementia can be very sort of, they can overlap. Then incontinence is one of the very important geriatric giants. Immobility. I hate older patients who don't move. The more towards the bed they are, the more scared I am because it might become long term and then that is not good for anybody. I mean, even as a caretaker, even as a doctor, that is not good news. Because that leads to the next geriatric giant, which is actually pressure sore or bed sore, which is very difficult to treat. I mean, any grade. I mean, we are okay if it is only first grade, but trust me, we are very scared that it doesn't increase on grade because it becomes very difficult to treat. A lot of people are bedridden for a while and then they might actually have, maybe they are even having weight issues, so they are overweight, so changing position and all can be very difficult. Then incontinence, which I said both, urinary and fecal both. People have fecal incontinence as well. And apart from that, the month, I mean falls are one of the very important geriatric giants because you can't treat a fall. You have to prevent it because you're treating whatever harm comes out of a fall, which again we'll talk about. So these are of course the major ones, but I also add to them some impairments. So there are three which matter a lot to me. One is visual impairment, hearing impairment, and according to me dental. You take out these three things, your quality of life is very bad. It is essential to live. So these three are very important when you look at actually older adults. And there is one more eye. There are a lot of eyes. That is atriogenic. So we as doctors should be very careful, especially with our drugs, because those are the ones which can, in a way, sort of lead to a lot of issues. So we have to be very careful. That doesn't mean we underutilize them, but at the same time doesn't mean we overutilize them.
Yeah. So we'll begin with the first set of questions. Dr. Kumar will take care of those about cognitive disorders in geriatrics.
Hello. Hello. Yeah. So the first question is, can you explain what is mild cognitive impairment and explain to us how MCI differs from age-related memory impairment?
I think one of the biggest scares that any older adult or their caregiver happens is once somebody tends to forget. Now the beauty about MCI is that is where we want to detect it. The beauty about MCI, unfortunately, is we are never able to detect because the patient comes much later. And that's why we need to know. So it's a mild form of cognitive impairment. It's in the name. But the good part here is that the quality of life is not affected. So functionally, the patient is still normal, but they might have memory issues. So that is known as amnestic MCI. Whereas people who have non-amnestic MCI means they will not have memory issues. However, they might have language issues. They might have issues in doing their tasks. A lot of times MCI, the older person might not realize themselves, but a caregiver might actually tell them. So this is about MCI, but how is it different than age-related cognitive impairment is very normal. So I'll give you an example. Like in MCI, what happens is you might not be able to do the normal things. For example, you have just been told to maybe write something and you're not able to. Then repetition is there. The person might keep asking again and again. Then language abnormality might also occur. Then in normal aging, you forget something, but it comes back to you. It might come in 15 minutes, it might come in 20 minutes. You lose your keys. Now the problem with dementia, which we will come, is that you will not remember anything. I mean, the keys are lost, you don't even know. Then direction. In age-related, you will not really you might lose on direction. Of course, I mean, in this day and age, we are so dependent on Google Maps that when actually there is a sort of roadblock, the Google Map doesn't show closed roads, by the way. So you'll use direction anyways. So it will come back to you. Whereas in a person with dementia, you will not remember anything at all. Then language. Now by language, I mean you might have a bit of difficulty in saying something, but then it's like, oh yeah, you remember it. Then you might remember faces, but after some time you might forget faces, but you'll remember it. So the key is in age related, if you forget something, it actually comes back to you. But in MCI, forgetfulness might be there, but other things might, as I said, amnestic, non-amnestic. However, quality of life will be entirely maintained, and that is why we say MCI, and that is why we want to get there, because if we are able to diagnose the person then we are at least hoping that the progression to the worsened dementia doesn't happen.
Hello. So the second question, how do you differentiate MCI from frank dementia, and how do you know that dementia is actually setting in?
Okay, now with dementia, of course, it's a huge gamut, but we'll get into it later. So the types of dementia, we'll get into it later. But in dementia, the progression is usually unfortunately slow. So it's not going to be always very quick. In MCI, as I told you, these are the things which might happen. There have been cases where in dementia, earlier signs also that the person is looking at the mirror and they are not able to recognize themselves, which was what you can say to an extent in certain patients when online consultations were not working, purely because the person was seeing almost 4 images. One is their image, second is the image of the people there. So there was a lot of confusion for an older adult who is actually having dementia. Then directions is a complete no-no. Wandering happens a lot. That's why we always say in a person with dementia at home, even if you are there, sometimes they might be able to open the door and they go out. I mean, you cannot obviously, dignity has to be maintained. You can cage them. So wandering is actually even encouraged. But if you have a bigger sort of home, they can wander around in the home rather than going out. So we always say, please try to have maybe some locket or at least a band which can actually tell us what the address of the caregiver is or where they live, or at least phone numbers. There have been cases where the police has discovered and they have called, and then of course they can, I don't know if I have to just quote I'm not going off topic, but what happens is visually when you see things, you remember better. So, and our great Dr. Mohan Agashe, who is also one of our leading psychiatrists, but also an actor. So he has in Marathi, he did a movie known as Astu. So Astu shows a very severe form of dementia. So if you remember that, you will be able to connect. Very simple, he loves seeing an elephant. This is a scene. He and the daughter is just busy in the traffic array. What is happening? She's shouting on the people. And he opens the door and goes behind. So obviously the elephant is not static, no? So it's moving. And she realizes the father is not there. So he loses his way, obviously. He has no idea how to come back. But that has been beautifully enacted. So that is about wandering. Then later, unfortunately, behavioral symptoms set in. And there is absolute disinhibition. The person will not care where they are, whether they are actually at home, whether they are out. So people have actually removed their clothes. In this thing where communication sort of is, as a caregiver, we cannot shout at them. What are you doing? Why are you not wearing your clothes? So there is another movie in which they have shown that the son also removes the pant and sits. The father is also, and makes him comfortable. And after half an hour, he realizes and he also wears the pant. So the key is we adjust to them. Don't expect them to adjust to what you think is right, because in their mind is very different. Then communication might completely be nil. People become completely they might not talk at all. Even that becomes very difficult to diagnose also. They are not talking at all, absolutely silent. Sometimes we actually prefer the aggressive ones purely because we know that what's happening with the disease. So, if you see with MCI, things are still okay, can be controlled, but these are the things which can actually happen. And as and when worsening happens, behavioral things like shouting, restlessness, hallucinations, delusions, then sleep disorders, and ultimately even hitting people. Now the thing with restraints is, I am not a fan of it at all, but you need to put restraints only if they are harmful to themselves or they are harming the caretaker, doctor, caregiver. So that is a call you need to take. In India, there's not a lot of legality in restraints. Abroad, there is a legality. If any injury happens to the person due to the restraint, the hospital can be sued.
When you say restraint, meaning they're tied to the cord?
Tying up, usually tying up is not what I prefer. We do something known as boxing gloves. But again, I mean, in that also I have seen patients, they are still able to sort of, I mean, the purpose is say that they can still move their fingers, but they cannot remove maybe if they have some Ryle's tube or other things or things to help them. And of course, chemical restraints again should be only used if you need to. See, using a chemical restraint is very, very simple. The patient will be totally knocked out, but that doesn't help you. That doesn't help the quality of life. You can't provide nutrition. You can't make them physically active. And people who can still be physically active, you should be very careful. So I think, so these are the things between MCI and dementia.
So the next question is, what are the commonest causes of dementia in India?
Okay, so I would say, I always say the marketed cause is always Alzheimer's, but we always forget that dementia is not only irreversible, there are reversible causes of dementia also. So if you, let me take the irreversible ones first. So Alzheimer's is very, I mean, it's dreaded, it's commonly seen. Then there is vascular dementia. Then there is Parkinson's associated dementia, sets in much later as compared to maybe earlier. Parkinson's symptoms of dementia are very bad. If a person has dementia with Parkinson's, it can be very bad. Then, of course, we have causes like dementia with Lewy bodies, in which there might be Parkinsonism features, but the person will be very aggressive. Then we have, of course, the reversible ones. Of course, there are rare ones like Creutzfeldt-Jakob disease, which is usually a prion disease, which is absolutely a diagnosis of exclusion. I mean, if you have ruled out everything, then only we have to look at, which is known as CJD. Then the reversible causes are ones which I'm very keen on actually knowing, because you have to, you can treat them. So one of the very simple ones is patient has a history of fall, no imaging done. Patient slowly, steadily starts worsening with maybe a confusional state, talking things which are not relevant. And then you do a CT, you can see a nice SDH which could have been taken out maybe earlier. A lot of people have chronic SDH also. You might have had a small SDH which is which you don't need to operate, but the patient is on antiplatelets. So then they sort of tend to bleed onto it and a chronic SDH.
So SDH, that is subdural hematoma,
Yeah.
has to be bilateral to be causing dementia, or
Not necessary, not necessary. Then, of course, normal pressure hydrocephalus is another thing in which classically there will be incontinence, there will be forgetfulness, and of course difficulty in walking or imbalance. Now again, NPH, as we call as short form, is not very easy to treat. Shunting can help, but usually they say that the forgetfulness might not really recover out. But again, it is reversible to an extent. Then very important is the thyroid profile. Hypothyroidism can cause cognitive impairment. Very easy to find out, very easy to treat. If it's missed, it's almost criminal. I mean, you can't miss a hypothyroidism. Then vitamin B12 deficiency again, and folic acid deficiency. So these are all very common things, but if we don't sort of look for it, we might not be able to treat them. So these are, of course, the various gamuts, and all of them are there in India, to be very frank, but the most common is Alzheimer's. The most dreaded is Alzheimer's. Unfortunately, that should not be the only one to be talked about. Why? Because people are all scared that they don't have Alzheimer's, but they tend to forget that they can have other types of dementias also, and then that gets neglected.
So the next question will be on Alzheimer's. Is pharmacotherapy for Alzheimer's being underused or overused in India?
Okay, I have an interesting anecdote to it. I don't think pharmacotherapy is underused. I think I won't say it's overused, it's used very frequently, but a lot of times not diagnosed, because I have seen people being started on donepezil, mementin, rivastigmine, and there is no real diagnosis. It's just maybe a history of cognitive impairment. But the real underutilization is the non-pharmacological therapies, which are huge. I mean, I have seen people with dementia, maybe in a moderate to severe stage, doing excellent art therapy. Excellent. They have never been artists before, but they respond to art therapy. They respond to music therapy. They respond to meditation. They also respond to intergenerational bonding. I mean, there was a study in the UK wherein people with dementia assisted living were actually kept with young people, newly borns. So these were people who, I mean, they were just meeting at some part of the day. So these were people who actually were very sort of aggressive, but when they were in front of kids, they were very, I mean, sort of, they were very normal. They were laughing around. They liked looking at that. So the stress should be non-pharmacological therapy should be stressed on a lot. However, we always should not wait for response to therapy. Non-pharmacological and pharmacological should be started simultaneously. Why? Because it cannot be कि मतलब वो बोलते ना, it's not like we have तीर कमान की बात नहीं है कि एक तीर बार मतलब एक करके निकालना है. We can take the entire thing because then we have the holistic approach to the person. And this is one of the biggest reasons dementia, people are still wanting to come now. Earlier dementia means, I mean the word dementia was just a death knell कि कुछ नहीं हो सकता है, don't do anything. Even doctors maybe earlier used to say that. But the non-pharmacological part is very much underused. There are a lot of intellectual companionships, there is something known as brain gym also which happens. Even if you have normal cognition, you have to make sure you maintain that. So a lot of memory exercises need to be done.
The next one is about donepezil. Can a family physician start donepezil, and what instructions do you give for the GP to start?
Again, I think you all could be in the best position to start it also. A lot of times maybe when you're a family physician, you're not a family physician for an year. Maybe you have been a family physician for that particular person for maybe around 15 years, 20 years. Maybe you are knowing the progression of when actually they are looking normal and when they're actually losing their memory. Again, but I would say maybe you should screen them first before just starting. For example, there are screening tools where you can ask questions to them and you realize that they actually have. And then of course, when you have any issues, you obviously need to refer, whether it's to a geriatrician, whether it's to maybe a neurologist, and then sort of continue your follow-up. Donepezil, Memantin, Rivastigmine, all good drugs, but all best used in mild to moderate. In severe, not much of a role is there. But all of them have certain side effects. The common side effects are bad side effects, like nausea, vomiting, dizziness. Dizziness in an older person is not a good side effect to have. Nausea, vomiting can kill them eating at all. And your nutrition, once it starts getting affected, quality of life will go, independence will increase. I mean, independence will decrease and dependence will increase. And that defeats your purpose. So before starting, the only thing I would say is what all drugs are already there, because drug-to-drug interactions matter a lot. And always go low and go slow, because there is, again, it's a thing which we do as geriatricians, but that doesn't mean we under sort of treat. For example, if there is an infection, you hit hard. You don't go low, go slow in that. But you can start with 5 milligram and then increase it to maybe 10 after around 6 weeks. Maximum is the 23 milligram dose. But if you see any side effects like nausea, vomiting, dizziness, drowsiness, then hold it back, because I have had patients who have had these issues. So it's like the relative, when they come, it's like before they were actually having a good quality of life. Now they don't have. So there is no harm is withdrawing the drug. Give them a drug break and try another line. Or this is where if the person is already on non-pharmacological therapy, so at least you have some line of therapy going on. See, the beauty about drugs is they work, but the beauty is also a bane because of the side effects. And in older adults, remember, we are not treating disease. We are treating disease in an aged body. So the interaction is much more.
One thing about drugs here is, you said if we detect MCI, we can do something about it, because if mild Alzheimer's can be treated with drugs like donepezil, can you treat MCI with donepezil?
Yeah, so in MCI, again, for example, it depends on what the MMSE score or is. If usually it's around 26, 28. But what is important is what is wrong. So for example, is the calculation part which is not okay. Is the recall which is not okay. And a lot of people, recall is the one which goes. So non-pharmacological, yes, the drug, of course, we should start in MCI only maybe after trying to do an MRI, seeing whether. Let me be very frank, MRI is not going to help you in diagnosis of dementia. It is only going to tell you which part is affected. So rule out Alzheimer's. And of course, if you have not done a CT and you are only going to do an MRI, it will also show you if there is any I mean, tumors are also something which can masquerade just as dementia. So it's for reversible causes. So it becomes like a single investigation, but you're able to rule out. However, doing an MRI in a person who is already bad and not MCI is very difficult. Especially if a person is already having symptoms of dementia, to put them in an MRI machine itself becomes very, and they get more agitated. So you have dementia with delirium, which is very difficult to treat again. So yes, I would say memory aid should be started. By that I mean reminders. I always tell people to write things down. I mean, we all used to write things down before this dreaded mobile came, to be very frank. Like my mother still remembers the numbers because she wrote all those numbers in a directory. We have a directory here. Earlier we used to create a directory. I mean, we used to have those A, B, C, D, E, F, G and remove it. Or we had the yellow pages, which was always there. But when we write more, we remember more. So we need to reminisce. By that I mean we keep repeating. That's how things work. So I would like to start memory aids in MCI, start non-pharmacological, see how they are progressing, and then try to maybe start medications also. If there are plenty of medications, I might have to think. For example, if they're already having multiple comorbidities, I might still have to take a call whether I should start it immediately or not. Yeah.
The last question on this is, what is vascular dementia and can it be arrested?
Yeah, I mean, we keep calling ourselves, I mean, we don't call, the world is calling us the diabetes capital. Then there is plenty of hypertension, there's plenty of cardiac illness, there's plenty of stroke, there's plenty of cholesterol, as Dr. Ajit Menon just mentioned in various answers. So I would say all these things actually lead to ultimately vascular dementia. Now, vascular dementia, the unfortunate part is it is not an acute insult. It's an insult which is happening throughout. So for example, it's very slow in progression. That's why we always say control the diseases. Diabetes, hypertension, dyslipidemia. If anybody has a history of cardiac illness or maybe a history of stroke, they're already at a risk of getting vascular dementia. So make sure that we are treating all of these. But at the same time, not only with drugs, with lifestyle changes. Like, I mean, you have to have changes, especially in diet, but flexibility is the key with older people. You cannot give them one, I mean, I'm sure a lot of people in this room itself, if you are just given a diet chart, you'll be like, oh, I forgot it in the hospital only. A lot of people might do that. You have to be flexible with the current diet. For example, a person with from Kerala, if you're saying don't eat rice, they are not going to come back to you. So you have to be very focused on, it's not about rice or it's not about chapati, it's always quantity, the amount of things that you say. So be flexible in making the proper diet chart. Exercise is very important. Again, word exercise comes and the older adult will just go first day 30, 45 minutes and that's the end of exercise. It doesn't happen again. Tell them to do it graded. Go 10 minutes first, 15 minutes more. You might know that they actually have bad knees already because you have been seeing them before. So tell them, no, treadmill you cannot do. But you can walk properly, slowly, steadily walk. A lot of people are gymming at their older age. Let us not underestimate older people. They are doing gymming also. But the people who are dying are the younger people who are in gym. Unfortunately, 35-year, 40-year-old. And these are people who have been fit. So the question happens is, how much should we do? That's why I always tell older people, please take your time. You don't have to be, I'll give an example of Usha Soman. Usha Soman is Milind Soman's mom. Milind Soman, we all know, is highly muscular and this. Usha Soman beats Milind Soman in a marathon. She is 75 only. So she's kept herself that way because she's doing it for years. So we cannot target being Usha Soman today, but we have to sort of make sure how much we can. So focus on the non-pharmacological one and in this lifestyle changes, especially for vascular, because most of the times people will already be on drugs. The reason I'm saying is multi-infarct dementia is very difficult to treat. If a person has multiple infarcts, various areas of the brain are affected, means blood supply is lesser. Slowly and steadily hallucinations will start, delusions will start, patients will be very aggressive. And managing them, I'm saying, not treating. Treatment is very difficult. Managing becomes very difficult because they are refusing to eat. So one of my patients refused to eat and came with ketoacidosis. She's a diabetes, but there was starvation ketoacidosis. So she had not eaten because she was refusing to eat and they were not able to force. So things like peg come into it, Ryle's tube. So a lot of risk happens, and then of course you might actually have to even restrain them. So what I say is more comorbidities, especially for vascular dementia, should always be controlled. Again, diabetic control is another very important thing. Go good, but not very strict, because we are more worried about hypoglycemias, and that is the solution.
Okay, so we'll go to the next topic. The next area is falls and orthogeriatrics. This topic we are trying to conduct in a kind of a Karan Johar style, rapid fire, and therefore you might have to.
Yeah, I'll keep it short. Yeah.
No, not just that, but very, very fast. So we'll. So the commonest fractures in geriatrics are fragility fractures. Tell us what are the commonest fragility fractures you see.
So I think one of the commonest fractures which are easily missed and are common are very vertebral fractures, to be very frank. Then of course hip fractures are there. We are also worried about radius fractures, which are very common. People usually come to the doctor if they have a radius fractures, but hip fractures can be easily missed because X-rays can miss hip fractures. So a lot of times we have to actually do an MRI of the hip to actually see. So these are usually the commonest ones.
They say that the short-term mortality of hip fractures is very high despite surgery. Is that true? And even if you operate early?
Actually, the problem with hip fractures is we end up treating the hip fractures, but we also have to make sure that the osteoporosis has been treated. So a lot of people discover osteoporosis only after the fracture is over. So we are dealing with a bad bone, but we are only treating the fracture. So ultimately, long-term treatment of osteoporosis is the key. But yeah, mortality is much higher in males as compared to females. So the thing is, if an older male falls and has a hip fracture, death is more. Older women suffers from osteoporosis. Why? Because they live long.
If you had to give just 2 tips on how to prevent falls at home, what would those 2 tips be?
So I think one of the very important things is for prevention is, of course, there are a lot of factors which are intrinsic and a lot of factors in environment. So I'll take environment because we're talking about home. So the toilet height is very important. We keep saying that is something we do every day. So if it is too low, it's not good. So getting the toilet height to a good, comfortable thing for the older, because a lot of people either fall front from the toilet or they fall on the side, usually while getting up or while sitting. That is one. Then secondly, the distance from the bed to the toilet also matters. So if it is for example, if it is in the same room, very close, couple of steps, it's very good. A lot of people actually have to walk through. So I have had patients who have had incontinence, slipped in their own urine, and then had severe falls and fractures. So that is another thing. And thirdly, I think clutter. A lot of things, clutter should be very less so that older people can actually navigate through the home. And you can put, I think, rails, or in bathrooms, especially anti-skid mats are very important, and maybe something to hold. It might not necessarily prevent falls, but if they actually slip, they're able to hold, so the fall might not happen.
Do you ever send your assistants or do you yourself go to geriatric homes to check what has been done of these things? Or should we do it as family physicians?
No, I also sort of do home visits, and I have also visited elder care homes,
okay,
where these things, because they the thing is, inception itself, when they are planning those homes, these are the things which come into their mind first. And now elder care communities are coming up, so where people are thinking of this first, that these are the things which should be there in a home where an older person. I'll give you an example. In the living room itself, there is a small sort of a window which can easily be broken by an older adult in case of fire. So whereas if that is not there, then it would be very difficult. And not at a height. The window is much lower so that they can break through. Yeah.
Do you think early recognition of osteoporosis and early treatment can reduce the number of fractures?
Yeah, I think early diagnosis definitely, but a lot of people do not do bone mineral density tests. Not because they don't know about it, but maybe they are not even told to do it. Because a lot of people think calcium, vitamin D we have taken, it should have sorted it out. But I feel our younger generation, maybe my BMD might be only 10 or 12. My vitamin D might be very poor because we hardly see sunlight. So more than anything, early diagnosis will always help because we are able to treat well. I think it's a cliched sort of thing that early diagnosis helps, but definitely because discovering osteoporosis after a fracture means you are treating what's happening with the fracture, and at the same time you're trying to strengthening the bone at the same time, which sort of becomes counterproductive sometimes.
When do you advise bone density in a non-fracture patient?
So I think anybody and everybody, if they don't have risk factors, should be doing it in the 50s for sure. Okay. If they have had risk factors, for example, history of taking steroids, then history of maybe cancers, then they should sort of do their bone mineral density maybe much earlier. For example, COPD, history of steroids. So
this should be same for males and females, age of recommendation.
Yeah, sort of.
Okay. Once you find osteoporosis minus 2.5 or less, what is your favorite form of pharmacotherapy besides calcium and vitamin D?
Yeah, so it all depends on the presentation. So for example, if a person has already had fracture, me and my orthopedic colleagues always like teriparatide more because it actually helps quicker. But it's costly and it can lead to the other side also. Sometimes it becomes so it becomes more difficult. Then our bisphosphonates are good, but oral bisphosphonates have their issues. You have to be very clear in telling the older adults how to take it. They need to take plenty of water, do not eat anything. After taking that also, they cannot lie down. They need to walk for some time because it is notorious to cause esophagitis. Then some patients I have seen maybe the jaw issues, osteosclerosis of the jaw, but not much. So that's not a bad drug, but a lot of patients, IV helps. Again, calcium should be seen and ECG should be seen, zoledronic acid if it has to be given in little frequency. Then denosumab is there. Of course, it's very commonly used in patients, older adults with cancer. Of course, ma'am would be the better person to talk about it. But yeah, it is sort of given. So these are the usual ones, but oral ones, bisphosphonates are used quite. My only thing will be please follow with these patients because how they are taking the medicine. A lot of times they might just think it is to be taken for life and they will not even consult, they will not tell you. So you might have to ask them, are they actually taking it, are they taking it properly? Because or else they will just come directly with esophagitis and that becomes very difficult to treat.
Within ortho-geriatrics, what are the other areas that you kind of, which are close to your heart? Like say osteoarthritis, spine disease? Yeah,
so it's osteoarthritis, then spine disease, then to an extent, of course, maybe even RA, rheumatoid arthritis also. But orthogeriatrics specifically has been created for making sure that fractures, that is hip fractures, are the ones which are addressed in an ideal situation, what happens is the person presents, a geriatrician immediately sees, gives fitness, makes sure the pre-op is ready, the person is done, and post-operatively. So for example, in AIMS, we have a separate orthogeriatric ward, wherein joint admissions happen and sort of joint care is happening. So they also take rounds and geriatrics also take rounds. So ultimately, once the post-surgical period is over and they are okay, so then we make sure that stabilization happens medically and then we send them home.
Yeah. We'll go to the next topic, incontinence. But before that, I want you to give us a message about how should we impose on ourselves the dictum of first do no harm in geriatrics. Any message? Are you seeing a lot of harm being done by us?
I wouldn't say that a lot of harm is being done. Purely what happens is a lot of times patients also don't tell you everything. They might be on Ayurvedic, they might be on other medicines. Nothing against that Ayurvedic or this, but the interaction is a problem. So when they don't tell us, a lot of times you might have to ask. So for example, I'll give you, if you ask all the drugs, so a lot of time older people don't even talk about syrups or ointments because according to them the drugs are only the tablets. A lot of times they might not even know the drugs. They are like my wife gives or my son or a daughter gives. So the Neela wala, the small wala, the white wala, the Pila wala. That's how a lot of people might even remember. So I would say the easiest way of not doing harm would be to check the drugs. Because a lot of times we start drugs, but they might go to other specialists. I have seen a person with 32 drugs. The person was admitted, obviously, And we slowly, steadily took out all the drugs. And then, of course, not suddenly. So it was almost a 10-day admission, and 7 drugs were there at the end where they went for home. So there were 2 types of ecosprin. There was 2 hypothyroid drugs, just different names. So what had happened is that the drug review had not happened. That is the only thing. And the older person was like, no, if the cardiologist has given that, the stroke specialist has given that, then how can I not take? So according to them, everything has to be taken. But we, of course, as geriatricians, always make sure that no, the drugs. So I think the easiest way of not doing harm would be to actually see the drugs, tell them to maybe bring the strips also. It helps, because a lot of times they feel drug means they'll just show you the list. And absolutely 99% it will not have the contents. It usually only has the pharmacological names. It will never have it will have the trade names. It will never have the generic content. So for us, we'll have to obviously see. So I think drug review, and I would say apart from that, preventive care is something which we can focus a bit more on, especially through vaccinations, because that also to an extent helps in making sure that nothing is sort of happening in the other way. And painkillers. I think painkillers are something older adults don't tell us. So they might take it over the counter also. So that becomes a big problem. That is one of the biggest heterogenic things that actually happens, and not necessarily that we have actually given it.
Okay, so now we'll go to incontinence. What is the predominant type of incontinence you see in elderly females and in elderly males?
Okay, so in females, it's usually stress incontinence. So commonly asked question should be hasne ya cheekne pe pishab chut jata hai. So that is of course stress incontinence. And in males, it's usually urge, and of course because of prostate. So that is one of the very common. However, stress incontinence also happens in males as well. It's not that it doesn't happen. Yeah, so these 2 are the most common. Then there is something known as functional incontinence. So functional incontinence is that a person's quality of life functionality is going down, and that is the reason why they are not able to. And then there are certain people who also have functional incontinence that because they cannot go toilet anywhere but home. So when they are going, by the time they reach home, they become incontinent. So that is also happening.
So how do you distinguish between the various types of incontinence clinically?
So clinically, I think although technology is coming, medications are coming, but the clinical dictum doesn't change. The clinical dictum to this extent is still history, physical examination. So history is very important. Like I said, if it is coming from coughing, sneezing, then of course it goes more towards stress. If it is typically urgency, frequency, hesitancy, then it will be more towards maybe urge incontinence. And a lot of times even overactive bladder can also be presenting that way. Best part in medicine, you all know, just because you want it, it will not be that way. So 2 types of incontinence can be there together also. There is also mixed incontinence. Then examination wise, I think the female examination for gynecology is very, very important. As older people, as they get older, they do not get necessarily a gynecological examination done. But we have discovered rectal prolapses, we have discovered vaginal prolapses, even bladder prolapses, literally things coming out. And that is causing the incontinence. So, you might be giving drugs, you are treating the UTI, but we have not done a gynecological examination. And then, so I think gynecological examination is very, very important. And then, of course, anal tone, when you are actually doing per-rectal, you will be able to see the anal tone as well, because a lot of times fecal incontinence happens. So that is also, and of course, a PR is something, of course, with permission, not everybody likes it get done, but PR gives us a good sort of thing of whether the prostate is actually enlarged. But a thing which should never be missed, especially in females, obviously, is the gynecological, because that really causes a lot of harm, because the older person is not sure what's happening. And when we ask, kuch samajh mein aata hai, niche aa raha hai kya? So they are like, pata nahi. They are not sure, because according to them, it's just incontinence. So urine is going off. And it's actually treatable. So, it's not that it cannot be treated, yeah.
What investigations will you do to distinguish the various types of incontinence?
So investigation wise, of course, I can start with the fact that you can help the patient sort of help you. So if people who actually have a urinary incontinence, you can tell them to get a voiding diary, just say how many times they have to go and total day. So that is, of course, when you ask them history. In investigations, I think very basic, acute urinary incontinence, UTI has to be ruled out. people might already have urinary incontinence, but now it has sort of gone very bad because UTI is there. So urine routine, urine analysis is very important, urine routine culture. Then apart from that, uroflowmetry is something in which, of course, our urological colleagues are very helpful. Then an ultrasound needs to be done purely because a lot of times we are looking for just the prostate in that, especially in males, but we also discover that, okay, maybe it's because of the hydronephrosis or it's because of other issues that actually the UTI is happening or the incontinence is sort of happening. Then plus minus X-rays might have to be done depending upon history of stones. Then again, if you have to go more invasive, a lot of times cystoscopy might be there to be done. If at all purely chronic UTI is there, you're not able to rule it out. And then we see that the bladder is actually sort of very thick. We have to rule out things. Then again, a lot of times urethral issues are there. So urethral dilatation itself helps because strictures is also something very common. So these are usually the basic investigations, and of course you might have to escalate it. For example, you might have to do a CT, abdomen, pelvis, depending upon what you're looking for and the presenting symptoms. So for example, if there is hematuria, then of course you need to look at other things. Yeah.
For treatment of incontinence, which is better in your opinion? Is it Kegel's exercises or pharmacotherapy?
Again, it's difficult to generalize. So for example, pharmacotherapy, there are drugs, but a lot of them cause more harm in older adults, especially the anticholinergics. But the other drugs like the beta agonists which is there, which mirabegron is there, that also is an issue because it can cause hypertension. So that is something we have to look for. But I feel basic things will be helpful, like the amount of fluids that an older adult takes, especially after 6 p.m. If you restrict the amount of fluids, then it becomes easier. Or else if they take more in the night, then that can cause incontinence. Very simple things like taking the diuretic in the wrong time. Because older adults, if they have cognitive issues and they are taking their own drugs, anything after 4 p.m. is hell. If you take a diuretic after 4 p.m., they might be urinating their entire night. So that is also something which is very sort of important. Kegel's exercises specifically is always helpful because it helps in strengthening the pelvic musculature. Specifically, it will be helpful in stress incontinence in both males and females, and not only in sort of females. And it also is very sort of helpful to an extent in overactive bladder also, to an extent, not much, and also in fecal incontinence. So I would say always a combination, but try to go for pelvic muscle exercises first. See if they actually need the medications or not, because again, I'm coming back to it. You might want to be adding one medication, but what the interaction with the level others happens, that would put you in a soup. Yeah.
What is your favorite anticholinergic for overactive bladder?
I don't have any favorites. I actually don't like anticholinergics. However, what has happened is oxybutynin and all were the older sort of, so they had horrible anticholinergic effects. People used to get UTI, people used to get urinary retention, dry eyes, constipation. But the newer ones, that is sulfenacin and derifenacin, are not bad. My urology colleagues have given to a lot of my patients and they are not doing bad on it. But we have to keep in mind that these side effects can kick in at any time. And if the person has dementia, then these things are not very good. If the person has Parkinson's, then again, these, unfortunately, those are the ones who have incontinence also. So it becomes very difficult. But we have to balance risk-benefit. I believe in geriatrics, it's not about only treating the patient. If risk is more than benefit, then take a call accordingly. But if taking that risk is benefiting the overall picture, like I'll give you a very simple example. A person is end of life, severe pain. And the choice is between actually making them sleep rather than suffering with pain. I think the risk of making them sleep and benefiting them to decrease the pain is better as compared to them suffering in pain, which is what usually relatives also choose.
When do you use mirabegron?
Mirabegron again is a good one, especially for overactive bladder. Again, a lot of patients have had. Now, what happens is it works only to an extent. It is not necessarily sort of the magic drug. But I have seen in certain patients that there is sort of improvement. See, our improvement is through symptoms. We are obviously going to see that. But I am always worried about the hypertension part because a lot of times people tend to get. So maybe you can start maybe at 25 and then increase by 50. And then see how the person is responding symptomatically, especially urgency, frequency, hesitancy. So if these are obviously getting better, I would always say do bladder training also simultaneously rather than only depending on drugs. Unfortunately, when we try to make these changes, compliance becomes an issue. It's always people are ready to take a pill, but not necessarily try to retrain their bladder. Retraining the bladder, believe me, if the effort is put, is much better and less side effects as compared to maybe the drug.
What is that? What is retraining the bladder?
Again, by avoiding diary. So making sure that we are only going to pass urine at this particular times. The beauty about our human bodies, it can be retrained. Again, it depends on the type of incontinence. So for example, if a person has got a spinal cord injury, we cannot obviously retrain their bladder because that's impossible.
What is the best treatment modality for SUI, stress incontinence?
There are plenty of treatment modalities, but I feel the Kegels exercises, that is pelvic floor muscular exercises, should be done first, always. Then plus minus, if we have to give the sort of drugs, we need to treat the diseases also. If a person has got chronic cough, a person has got COPD, they'll keep coughing. So that will keep causing stress, incontinence. Loss of weight helps a lot because a lot of overweight people actually tend to have stress incontinence. Then, so these are of course the behavioral things. We can actually go into other things like surgeries as well. A lot of times even estrogen helps, especially in female. Estrogen creams are commonly prescribed by the gynecologist. That's why I again reiterate, gynecological examination is very, very important. Not commonly asked for by the patient, but you need to sort of tell them and even convince the caregiver that is actually not necessary but mandatory, because ultimately if you do it and everything is normal, it's okay. But if you discover something, you're able to. Then if you discover a prolapse, then surgeries sort of come in, especially the sling surgeries, of course, which our gynecologist and plus minus urologist obviously might have to be involved.
I think we are at the end of the lecture, and I'm sure it has been you can see that Dr. Prem has so much information to give and so much knowledge to share that 1 hour is not enough for this person, right? And we will. We'll be coming to geriatric vaccination in another, the next topic. But yeah, as you correctly said, there are so many topics that he can speak on and he can empower us with. And as the only MD geriatrician I know in Mumbai, I think you are somebody we'll be catching hold of again and again. We'll be giving a big hand, and we will be taking questions. He'll be here. We'll be taking questions even in the break. And thank you, Prem, for being here. We'll ask him in the break. Because many herbal questions will be there, I'm sure.
My quick comment to that will be Kerala would be dementia free, and that's not true. So yeah.
Well put. If you like Singapore, you remember it?
Not really. I don't remember it now.
Next time.
Write something.
Next time. Thank you. Thank you so much.